How is my sound? Can you hear me okay? I see we have two students, Tanya and Amber. Okay, can one of you confirm that you can hear me?
I can hear you.
Okay. What I wanted to do today was just to wrap up this module 2. Not going to have any quizzes this week, but next Friday we're going to have the midterm. So you'll have plenty of time to study for it. And it will be just like the last exam. It'll have a couple of essay questions at the end. And mostly multiple choices worth 30 points. It's just going to cover module 2, which of course is how drugs work in the brain, emotions and stress, depression and schizophrenia. And I don't think y'all had anything on bipolar disorder, but it is a different condition from unipolar depression. And it's diagnosed by having at least one manic episode at some point in the course of the disease. But most patients spend most of their time in the depressed state. And of course, the treatment's a lot different, as we stay away from antidepressant medications because that can trigger a manic episode. And they need to be on a mood stabilizer such as lithium, Depakote, or carbamazepine. And in the recent years, the atypical antipsychotics have several that are approved for treating all phases of bipolar disorder. But the depressive symptoms are pretty much identical to unipolar depression. I just wanted to bring that up because I didn't see it anywhere in the module there. But I want to speak briefly about schizophrenia today. It's probably the most serious condition that we see in psychiatry. It's usually pretty debilitating to the point that a person has to have a support system. So usually just one physician cannot handle a serious case of schizophrenia alone. It usually takes social workers, sometimes nurses, therapists. And there are what's known as ACT teams, assertive community treatment teams, which can actually go into the patient's home and they have contact with somebody several times a week, mainly to prevent hospitalizations, as one hospitalization can cost upwards of $20,000 or more. So over time, we've learned that the best thing is to keep the patients from decompensating. And that's happened a lot through long-acting injectable medications. There are medications that last up to 4 weeks. And they have come up with one that lasts up to 3 months. And just this very week, there's one release that will last up to 6 months. So that's only 2 injections a year. And with the long-acting injectables, that eliminates the problem of compliance. So you know they have their medication because you gave it to them. And that prevents relapse. There's been data to prove that that is one of the best treatments, is long-acting injectables as opposed to oral medications. But first of all, what is schizophrenia? It's basically a chronic lifelong condition that deteriorates the mind even further over the course of a lifetime. Most schizophrenics have a 20-year less life expectancy, and a lot of that is due to habits that they develop, such as smoking, poor diet, sometimes substance abuse. The primary symptoms of schizophrenia are the positive symptoms. Positive doesn't mean good, it just means that they're present. And the trademark, of course, is hallucinations, usually auditory hallucinations. Visual hallucinations are much less common. The other symptom is delusions. Delusion is a belief of something that is not true, or seeing something very odd or supernatural about things that other people are not able to connect with. Delusions are the most difficult symptom to treat, because once a person believes something, it's hard to just give them a pill and make them stop believing it. And if you challenge them, they tend to dig their heels in, and it gets worse. So it's a very fine art to dealing with someone with severe delusions. You don't enforce the delusion, but you also don't challenge it, because that tends to make things worse. Negative symptoms are pretty much the absence of anything. The person has apathy, shows no emotion. Anhedonia, they find little pleasure in things. And they have a flat affect. And cognitively, they are also slowed, so they don't really think in a normal fashion or normal speed, or comprehend things as well in general, but there are exceptions, of course, to that. The newer atypical antipsychotics are designed especially to treat these negative symptoms. And it is amazing to see someone come to life once they have a successful treatment, because they appear to be like a totally new person. The genetics of schizophrenia, even if you have identical twins, it's not 100% correlation. It's only 50% at the worst case. The general population, the the percentage of having schizophrenia is 1%. And that's been pretty well documented over years. And this is just a chart that shows that even with 100% identical twins, there's only 48% correlation. And two schizophrenic parents is about the same. A child would have a 1 in 2 chance of developing the condition. Fraternal twins, much less. And just a sibling, less than 10%. And an unrelated person in the general population, 1%. And that word I was trying to think of was incidence, how often it occurs. The neurochemistry, dopamine, of course, is at the center. It's a lot more complex than that, but it is pretty much known that there's an excess of dopamine in the brain in places where it shouldn't be, such as the frontal lobe and prefrontal cortex. And virtually all the drugs, especially older ones, are directed at the dopamine type 2 receptor. And there are, I think, about 7 or 8 different dopamine receptors, but the dopamine 2, D2, is the target where all the clinical action has been. The limbic system is believed to be one of the main areas, and of course the limbic system is the center of emotions, anger, sadness, fear. All of that takes place primarily in the limbic system. It's been noted that giving stimulants to a person with schizophrenia makes it worse, and the mechanism of action of stimulants actually is a release of dopamine and making dopamine more available to the brain. So that's just another fact that confirms that dopamine is quite important. In Parkinson's disease, it's a deficiency of dopamine in the substantia nigra, which is a different part of the brain than other conditions. It's a part where movement is regulated, and a person with Parkinson's disease eventually loses their ability to move normally. But the point I was going to make is that the treatments of Parkinson's disease also causes psychosis as a side effect. There is a new drug now, I don't know the name of it, I don't remember, but it's specifically for Parkinson's patients that have psychosis. The other neurotransmitter, glutamate, as we have learned, it is the main excitatory neurotransmitter in the nervous system. And it also is very important in this condition, but we are just catching up now with the research, and they're designing some newer drugs that will target glutamate. But right now, I think there's only one, and it is not used a whole lot. But in the future, glutamate will probably become just as important as dopamine has been in the past. But there are several things in the pipeline. This is probably the most exciting time to go into the neuroscience field, because there's a big frontier out there that is, we just scratched the surface of it right now. And there's been a great explosion in the last 20, 30 years of what was available and what's there is to use, what tools. I know almost all of my career, there was a condition known as tardive dyskinesia, which was the most dreaded side effect of the use of dopamine blockade. And the problem was that it was usually irreversible when it happened. And it just involved sometimes severe involuntary movements of the muscles. And that was kind of what you dreaded because there was no treatment for it. And if the patient was really uncomfortable with it, then that was not a good situation because you may have helped one problem, but you created another. But just in the last few years, they've developed not a cure, but a treatment that's very effective. Medicines Ingrezza and Austedo, and they're what's called a VMAT inhibitor, and they are designed to regulate the dopamine in the neurons, and they actually do that, and they have very few side effects, hardly any side effects. But of course, as always, the big problem is the price. They're medicines of thousands of dollars a month to use. Fortunately, many patients do have Medicaid, which does actually a good job of covering most drugs. Medicare, not the same. I think people of Medicare get a raw deal because they basically are forced to use generics, or if a medication is prescribed that's name brand, it may be approved, but then the copay may be $500, which no one can afford. So that's one area where we have to make more progress. But again, the drug companies' belief is that if someone can't afford the medicine, they'll just give it to them free. And by doing that, they don't have to lower the price. They can keep it at a very high level. But that's just how the system works there. Mechanisms of antipsychotic drugs. At one point, the only drug was Thorazine. And then there was a breakthrough. Haldol came along, and they both are D2 blockers, but Thorazine is extremely mild as far as the binding to the receptor. So you have to take pretty high doses to get an antipsychotic effect. But Haldol is what we call the sledgehammer. So it's very concentrated, and it binds very tightly to the D2 receptor and is very, very effective, but has a lot of side effects, especially if the receptors are oversaturated. Theoretically, you need to saturate 80% of the D2 receptors to get an antipsychotic effect. But how do you know when you get to 80%? The old days, when they started having side effects, you knew that you had a therapeutic dose and you could start backing off. There's something called cogwheeling, or it's a Parkinsonism type symptom, where you bend the forearm forward and backward, and if it has kind of a cogwheel type movement where it not clicks but has resistance at several different positions, then you know that the medication's at a therapeutic dosage. So Haldol is great. It's still used some today. However, not in larger doses like it once was. It pretty much knocks out all the positive symptoms, the hallucinations, and may not knock out the delusions, but I think the patient just forgets about them. They're not so consumed with them. However, it does very little for negative symptoms. And many times you'd see the patient, I know you've heard people say they look like a zombie, where they're just staring into space. So they may not be psychotic anymore, but they're what would some people call better. But that's why there was a search to come up with newer drugs. And some of the newer drugs, such as risperidol, Zyprexa, Seroquel, Headen, Abilify, and now Vraylar, Latuda, they have specificity for the serotonin receptors, and therefore they're able to regulate the serotonin within the synapse. And by doing so, that addresses the negative symptoms. And these drugs are miraculous considering where we were 50 years ago. There's also designer type D2 binding drugs known as partial agonists. And what a partial agonist does is, if the dopamine is too high, it automatically lowers it to an acceptable level. If the dopamine is too low, it automatically raises it to an acceptable level. Two of these drugs are Abilify and Vraylar. They're partial agonists. So it's kind of a step above what we're actually studying now. But that gives you an idea of what the future holds there, is that drugs are going to keep getting better and better as time goes along. And what we're hoping for is at some point you can just give somebody an implant or an injection once a year, and you don't have to worry about the pills anymore. And that is not that far away that could happen. As far as the neuroanatomy and schizophrenia, there are changes or differences in the brain of a person that's schizophrenic. What the specificity and meaning of all that is debatable, but we do know that there's less axons and less brain cells, white matter. And we do know that because of that, the ventricles in the brain get larger than what they should be, because there's not as much neural matter as there should be. And there are other subtle changes there in the hippocampus and the frontal cortex and the basal ganglia, the thalamus. So physically, there are some differences in the brain of a schizophrenic and someone who's not a schizophrenic. And that just kind of supports the science even more. But the actual cause of schizophrenia, no one's been able to give a nutshell explanation. There's things about birth and chemicals and genetics and several different theories. But we do know how to treat it. That's a good thing. Integration of brain circuitry and transmitters It's not something you really need to spend a lot of time on unless you're interested in research or really studying the brain intensely. But it's just talking about the basal ganglia and the thalamus and the connection with the cortex and whether the effect is inhibitory or not. Okay. And I think that's all we're going to need to cover on schizophrenia. Did anyone have any questions at all?
When's the midterm? The midterm?
When is it? Oh, next Friday, the 15th.
And is it just like?
It's going to be just like the last test, but it's going to cover the whole second module, module 2.
So it's just going to be on module 2. It's not going to be cumulative?
It's going to be like 90% on module. That's,
okay.
I'm just getting ready to go over the. Make sure you read the script right here, because everything you need to know about what we talk about today is in here. And I'm not going to do quiz 4. We'll just have it all included in the same. And
for discussion 4, when is that due?
I'm sorry?
When is discussion 4 due?
Okay, yeah. I have to decide on that. Have you all already started on it?
No, but it says it was due like September 26th, but it says you posted it October 3rd. So I think it's just the old dates.
Okay. Well, we have the exam. I'm not really going to have a due date on it, but you can start it now. Again, the main thing is I'm looking at participation. I want everybody to participate and just show that you're understanding what's going on there. So I'll go ahead and release it today, and we're not going to worry about the due date.
And I know on Monday you had mentioned that we weren't going to do we probably weren't going to do the writing assignments that he did. And I saw the first one is on there, the summary 1 assignment. Are we not going to do that for sure? I just want to make sure I'm keeping up with everything. I don't want to fall behind.
Yeah, well, it was the papers that I was eliminating, but you'll still have the essay questions at the end of the exam.
No, it says, like on my screen, I can see it's under, let me see, it's under module 2C, and it says summary 1, influence of genes. I think that is the paper because it says it's like a 2-page paper.
Yeah, we're not going to do that.
Okay, all right, thank you.
Okay. Okay, and that's the guide for quiz 4. There was a guide in here for exam 2 also. But just like before, we're going to go directly by the guide. If you know what's on there, you're going to be in good shape.
On our end, the guide is at the bottom of 2C, right above the exam.
Okay. B to C. That would be right here, yeah. Okay, I'm just gonna run through this real quick to see if there are any real concerns there. Of course, there's gonna be the neurotransmitters and the synapse, drugs and addiction, need to be familiar with every class of drug there: stimulants, depressants, opioids, psychedelics, cannabis, and have a general understanding of psychiatric medications such as serotonin reuptake inhibitor, D2 blockers, and just have a general understanding of how they theoretically work to treat depression and to treat psychosis. Know the difference between an agonist and an antagonist. Of course, an agonist enhances effect, and antagonist slows it down or blocks it. And all these drugs have a receptor that they bind to, and they have that one or the other effect. As far as partial agonists, you don't really have to be too concerned about that. That's kind of a newer term. Okay, and the general principles of abuse and dependence, escape from stress and pain. It's usually how people begin with an addiction. Understand the different routes of administration, meaning that the inhaled drug through the lungs is the fastest way to the brain. IV shooting up is the next fastest. And by the time someone gets to these points that they're using in that way, they're extremely sick or at a bad place, and they need a serious treatment program. And just understand how difficult it is to treat people unless they really want to be treated and they really want to put in the work that's needed to recover successfully. Synergism, that just means that one drug enhances the other to a potentially toxic effect. And certain drugs you shouldn't give together, like opiates and benzodiazepines. That's what the big thing is this day and time, is to avoid giving those two, especially in someone that's not reliable or responsible, because just a couple of extra pills could be enough to kill them. Tolerance is when the drug begins to work less as you take more. And that's another common problem with meds like benzodiazepines. It's kind of like getting on a conveyor belt. You have to keep increasing the dose and you're not getting any effect, and they would have to go in the hospital to actually come off the medication, because benzo and alcohol withdrawal is one of the more dangerous ones, due to the fact of causing seizures and DTs. And DTs actually has a high rate of mortality. Okay, condition tolerance, acute tolerance, just the two types of tolerance. Most drugs are dose related, and they have different metabolism rates. So some drugs you have to have a peak level and a trough level, because the drug may be in the system, but it may not be effective at the trough level. And that's just something you need a basic understanding of. Understand the placebo effect. Basically, 30% of people are going to get better if you just give them a sugar pill. And that's across the board. It's always been that way, known as the placebo effect. In clinical trials, usually one group receives a placebo and the other receives a medication. And you'll notice that some people receiving the placebo actually get better. Most of them don't. And usually the study is halted once they're able to determine that the medicine is effective. Withdrawal, again, is very severe in alcohol and benzodiazepines or barbiturates. Withdrawal from cocaine is basically just craving and severe dysphoria, so bad that the person will do just about anything to get some more crack. Opioids are probably symptomatically the worst of all withdrawals, but nobody's ever died from opioid withdrawal, so it just feels horrible. But with opioids, the danger is in overdose. A lot of times people go into treatment and go through all the withdrawal, and they come out and they start immediately using the dose that they were using before, and their body doesn't have that tolerance anymore, and they die. So that's extremely common. And after someone's released from treatment, that's the most vulnerable time that they really need to be monitored and in some type of NA program, and definitely not in a situation where they're in the same environment or where they're alone, don't have anyone around them. Brain areas and drug effects dependence. This is just talking about the dopamine pathways here, the nucleus accumbens and the ventral tegumental area, or VTA. And it talks about whether a person just wants the drug or whether they like the drug. Over time, most addicts stop even liking the drug. They just have to use it to function at a minimal level. And that's because this system in the brain has been hijacked, and it's not doing what it was intended to do, but it's just taking all the person's energy and resources just to continue using the drug that they're addicted to. Dopamine is at the center of this, and drug-seeking behaviors are extremely common in people that have an imbalance in their dopamine. That is the reason that crack is so addictive and crystal meth are so addictive. Crystal meth is just a long-acting form of crack. So you only have to use it once a day instead of 3 times a day like with the crack cocaine. Let's take a look at the animal models again, and it demonstrates with the rats of how the addicted rat continues to drug seek even when the drug's not there, and even when he's shocked with electricity, he still continues to go after the drug, whereas the non-addictive rat is immediately turned away and is unconcerned about whether he gets the drug or not. And this can be extrapolated to human beings. And that's why we have to see addiction as an illness and not a weakness in moral character or that type thing, but it is a chemical illness that requires specific treatment, and most importantly, desire to get clean and to get better. If that piece is missing, then it's really a challenge to get anywhere with that type of patient. We talked about stress and emotion. Remember, emotions generate from the limbic system, and the limbic system communicates with the frontal lobe. Frontal lobe is the boss, and it has the power to override that limbic system unless it can be tricked. into believing that an emotion is warranted, even though it may not be. That's when a person is really in trouble, is when their frontal lobe is no longer doing its job. And that's why cognitive behavioral therapy is a must in almost every treatment, because it teaches the person to override things that may be irrational or not in their best interest. The amygdala, of course, is the main player in the limbic system, and that's where all the fears are filtered through. And if the amygdala doesn't shut down when it's supposed to, panic attacks can occur and just constant anxiety can occur. The amygdala and the hippocampus, of course, communicate with each other. The hippocampus brings up memories of stuff that's happened in the past, and the amygdala either turns on anxiety because of it, or it doesn't. If it's something that the hippocampus is processed to be a non-danger, well, the hippocampus and the frontal lobe, then the amygdala in a normal person doesn't fire excessively. Understand the axis with the adrenal glands. The acute reaction, of course, is epinephrine release and the fight or flight response. And this is mediated through the hippocampus, not hippocampus, the hypothalamus, the pituitary, and the adrenal gland. Epinephrine is produced in the adrenal medulla. Remember, epinephrine is both a hormone and a neurotransmitter. So it's the only neurotransmitter that functions as both of these. The chronic stress reaction is known also as a passive reaction, and that's the hippocampus to the hypothalamus to the pituitary and the cortex of the pituitary, which manufactures cortisol. And in chronic stress, cortisol is released, and initially it has some benefit in fighting stress, but as time passes, it becomes harmful and dangerous. It binds to the hippocampus, causes it to shrink, causes it not to regenerate neurons. And if it goes on for an extensive amount of time, the patient will be stuck in a place where they're severely depressed and not functioning and not able to recover. So that is why it's so important to treat depression early and treat it appropriately to avoid the long-term effects, which can be devastating and result in high morbidity and mortality. Okay, that was a passive. And this is just talking about cortisol. I gave you the highlights of what is important to know about the cortisol. Mood disorders, always remember serotonin. And we talked about the P11 gene that is a relatively new discovery, and it's something that makes the receptors to serotonin more available. And people that don't have this gene, they're more vulnerable to stress and more likely to become depressed. Again, norepinephrine, serotonin. When you see norepinephrine, think of anxiety if it's an excess. If it's a deficiency, it's going to be difficulty with memory and pain management. But of course, all these neurotransmitters have several functions, but you want to try to remember the main functions. And by doing so, that always keeps you on the right track. Okay, this talks about the hippocampus and how there's neurogenesis there. At one point in the past, it was believed that brain cells don't regenerate, but we now know that to be false. And we know that it's important to treat a condition as if that's false, so that a person has a reasonable chance at recovery. There's a parallel between physical and emotional pain. Pain is pain. Brain doesn't really distinguish in the long run. So you get the same stress response from emotional pain that you would from physical pain. Lots of people believe the emotional pain is worse than the physical pain because physical pain is more likely to be short-lived. Emotional pain can last a lifetime. Okay, we talked about the passive coping and stress circuit, serotonin transporter gene, animal models of depression, the treatments for depression. Of course, the traditional antidepressants are the mainstay of treatment. If those are not effective, there are other options, such as the Maoi inhibitors, which, as I said, is like a shotgun approach where it hits serotonin, norepinephrine, and dopamine all at the same time. And by inhibiting this monoamine oxidase breakdown enzyme, it makes these more readily available in the synapse. But as I said, they are rarely used anymore because the need to be on a tyramine-free diet and the risk of a hypertensive crisis, which can be serious if it happens, but it's almost unheard of now because that drug is rarely used except by some of the older psychiatrists. SSRIs are the safest drugs, and that's why they are used the most, because you're less likely to get into any trouble or predicament with them. Usually the worst thing that happens is they don't work. And it takes about a month for them to kick in, so that's a downside too. Is patient has to take the medication for 2 to 3 weeks with basically no effect at all, and they wonder why they're taking it, and many times they will discontinue it. Some of the newer treatments, alternative treatments, ketamine is the only treatment that works immediately, and I don't think they really know exactly the mechanism, but we do know that the person goes into a dissociative state, and in some way that resets the brain. But there's a lot of risk with using it if it's not done in a highly specialized clinical setting. So therefore it is not that popular. It's not a drug you want on the street either, because there's a high street value for it, and it's commonly abused when available. Transcranial magnetic stimulation, a stimulation of the frontal lobe and the dorsolateral prefrontal cortex. Just know what it is. You don't need to know very much about it. ECT is the most effective alternative treatment, and it works in up to 80% of people. But the price is some memory loss. But other than memory loss and occasional headaches, there's really no side effects to it. It's reserved as a last resort treatment. And that's mainly because of the logistics of doing it. But it also has a negative stereotype because of the movies and things people have seen in the past, but it's actually safe because you have anesthesiologists, you have a psychiatrist, and you have nurses and other technicians, and it's just about always done in a hospital. So very rarely do you hear of anything negative happening there. Deep brain stimulation is a surgical procedure where the probe is inserted into the cingulate gyrus. And as far as the specifics of how it works, I don't want to even try to get into that right now, but just know that it exists as a possible treatment when nothing else works, or when you are a millionaire and you have a lot of money to try all the treatments. I spoke of bipolar at the start, but the main thing you need to know about bipolar is it's a separate illness from unipolar depression. It's highly hereditary, runs in families. To diagnose bipolar disorder, a person has to have had at least one manic episode at any point. If that has happened, then they're not unipolar, they're bipolar, and it's very crucial to make the right diagnosis there, because if you diagnose a bipolar patient unipolar and you treat them as a unipolar, you will make the condition worse by giving them antidepressants. And unfortunately, that's how a lot of bipolar patients end up being diagnosed, is they are flipped into a manic episode. And when that happens, you're pretty sure about the diagnosis. And the treatments for bipolar are mood stabilizers like lithium, Depakote, carbamazepine, or atypical antipsychotics, which the industry is leaning a lot more toward now because of the safety profile and the fact that the ones that are approved are pretty effective. Panic disorder, just remember the nucleus ceruleus, which is located in the pons, and it's a major source of norepinephrine in the brain. And in panic disorder, there's an excess of norepinephrine, and the balance of norepinephrine, serotonin, dopamine is off. And practically all the treatments we do are through the manipulation of one of these three, or all of these three neurotransmitters. And that always brings up the interesting question of why do you give antidepressants to someone with an anxiety disorder? And basically it's just a matter of balancing. And usually giving the antidepressant is not going to work immediately. It's going to take some time for things to get back in balance. Part of the treatment for panic disorder has been benzodiazepines for PRN or short-term use, but not to the degree where you would increase the risk of an addiction or a tolerance there. The cognitive behavioral therapy is a crucial component of treating panic disorder. Learning breathing exercises and other tools that the person is able to feel in more control. That is the worst thing about anxiety, is a person feels out of control. They feel like they're going to die or some horrible thing is going to happen. But if you can give them tools to help them feel more in control, it can be an effective part of their treatment. And always remember that the prefrontal cortex and frontal lobe always has the last say-so of what's going on. And it can override the other parts of the nervous system. It has the capability of doing that. It doesn't always do it though. And these are just examples of what the essay questions will be like, and they will be very similar to this. Some of them may be the exact thing here. So just make sure you're prepared to answer at least 3 of these. Okay. And I'm going to go ahead and open up the next module. You don't have to start on it yet unless you want to. But just prepare to be ready by next Friday. And going to be pretty much like the previous exam. And if you know everything that I went over here, you're going to be in good shape. Any specific questions right now? Okay, what's today, Wednesday? Okay, well, I'm going to see y'all on Monday. Email me if you have any questions, any problems.
On Monday, we actually have fall break, so we don't have classes on Monday.
Okay, I was wondering when that was. So is that all next week, or?
It's just Monday and Tuesday. I think we have classes on Wednesday again.
Okay, I'll see y'all on Wednesday then. Have a good afternoon.